started. So welcome. Welcome everybody. Just a few ground rules. Please go ahead and turn your camera off just because it can kind of interrupt bandwidth. We'll take questions at the end, but meanwhile, go ahead and put them in chat if you like. And closed captions are available. The instructions are right there. So our presentation today is on latent tuberculosis infection. My name is Heidi Boehm. I am the TB controller and nurse consultant for the TB program at Oregon Health Authority, and I have with me Kevin Winthrop. Do you want to introduce yourself?
Yeah, hi guys. I'm a professor of infectious diseases and epi at Oregon Health Science University, and I've had the pleasure of working with Heidi for a long time now as the medical consultant of the state. So thanks.
Exactly. There are a lot of acronyms with TB, unfortunately, so here is a long list of them for your reference. Okay, so just a brief overview about LTBI or TB disease. Which one is it? So with latent TB infection, the person usually has a positive IGRA, that is a blood test for TB. That would be a quantiferin or T-spot. And their TB skin test is positive. They feel well. Their chest X-ray is normal, and they are not infectious. And treatment should be considered for LTBI, and that would be taking 1 to 2 drugs for several months. Okay, for TB disease, the person usually has symptoms. They might include a fever, chronic cough, chest pain, weight loss, and night sweats. Chest X-ray is usually abnormal, but it could be normal if there's advanced immunosuppression or extrapulmonary TB. And you'll find that the respiratory specimens are positive for TB. And then if the TB is pulmonary, the person will be infectious. And you treat the person by having them take 3 to 4 drugs for at least 4 to 6 months. Oops. Kevin, can you talk a little bit about maybe the continuum here?
Yeah, I always like to say this. So Heidi, thanks for inviting me to say something about it. But yeah, just this distinction between latent and active is just a fiction of our words. It's really a continuum, as Heidi said, and it's a very dynamic process. So, for example, there'll be people with kind of latent TB. I mean, they don't look like they have anything going on. But the TB will awaken periodically or grow or try to progress, and the immune system will then hustle and shut it down. I always explain to patients as a little tug of war between the immune system and TB. So sometimes TB is winning for a few weeks, sometimes the immune system is winning for a few weeks. And overall, the TB is kept in check, doesn't really grow, doesn't really spread, but it is alive. And there is this delicate relationship going on. And so there are patients where you'll see them reactivate, then they'll go quiescent, they'll reactivate, go quiescent. And they can go on like this for forever. Most of this is all subclinical, but again, sometimes it's not. So you'll find people that have old healed lesions of active TB, evident on their chest CT, for example, and they have no knowledge that they ever had TB before. They weren't even sick, but that it was actually active. So that's the continuum. And we like to just kind of think about it as persistent TB infection. It's either really active or it's not. So
Thank you. Sorry for the slide flipping here. I somehow lost my video panel, but that's okay. We'll carry on. I don't really need it. Okay, thank you, thank you. So who should be tested? People who are at high risk for TB should be tested. And really, we recommend that you do not test the general public because of the risk of getting a false positive result. There's a QR code there you can check on if you want to see the US PSTF recommendation for latent TB infection and who should be screened. So there are a variety of TB risk factors, mostly, due to exposure to or infection with TB. So the risk factors would be close contact to people with TB disease. It would also be people who are born in or who frequently travel to countries where TB disease is common. And there's a list of countries right there. Typically, we exclude Canada, Australia, New Zealand, and Western European countries or Northern European countries because people coming from those areas are not at high risk. Residents or employees of congregate settings, and infants, children, and adolescents exposed to adults who are at increased risk for LTBI or TB disease. And then some of the risk factors for developing TB, if you've been infected, would include HIV or AIDS, induction drug use, diabetes, long-term use of immunosuppressive medicines, chronic renal failure, lymphoma, malignancy, substantial weight loss, or gastric surgeries. Okay, so here's a question for you. You can either think it through or put it in chat. So, CDC guidelines recently recommended stopping annual TB testing for healthcare personnel, and hopefully, all of you who work in healthcare, you stopped that because we implemented this in Oregon some time ago. During your annual TB education at your hospital, healthcare personnel comes up to you and says they recently returned from mission work in Europe. What would you do? Not Europe, I'm sorry, Ethiopia, completely different. What would you do? You can go ahead and put that in chat if you know the answer. Okay. So, yes, what you could do is offer TB screening. This person has a new risk for TB because they spent time working in a high risk area in Ethiopia. So, we would recommend that they get tested for TB with either a TB skin test or quantiferon or T spot test 8 to 10 weeks after they return to the US. Okay, so now we're going to move along to diagnosis of latent TB infection. So just a little bit about LTBI. The TB skin test and the IGRAs both reflect immune sensitization. They're not really direct proof of an infection. So when somebody's infected, a reaction is usually detectable 2 to 8 weeks after the infection. LTBI is pretty common worldwide. About 20% of people are probably infected. Many, many countries do not test or treat for LTBI because they just don't have the resources to do so. We know that some people who inhale TB likely clear the infection and just have no live germs at all in their body. So, in the end, about 5 to 15% of people with LTBI develop TB disease sometime during their life. And that really depends on, the age they acquired the TB, LTBI during, or what happens in the course of their life, such as if they get an immunocompromising condition. The TB skin test and the IGRA cannot be used to diagnose TB disease because they could be falsely negative. So in general, the current tests for LTBI are really not great and they're not perfect. We hope in the future that, we'll have a test that better predicts who will develop TB disease. Kevin, is there anything you want to add?
Yeah, I would just stress the point you made about the TST and IGRA because I see this all the time. People are being worked up for active TB and they're ordered a skin test or an IGRA. And usually mostly now these days it's an IGRA. But again, trying to remind those people that it might help you sort out if they've been exposed before, but it's not going to actually help you diagnose active TB. And the false negativity issue is real. About 15 and 20% of people with active TB will actually have a negative IGRA or a negative skin test. So the immunosuppression associated with TB is enough to overcome the sensitivity of those tests. So it really is important to remember.
Yep, thank you. All right, a little bit about the TB skin test. And again, there's a QR code where you can look up more detail on how to place and read a TB skin test if you're interested. Just a reminder, you only really measure the bump and not the redness. So you only measure the bump when you're measuring the TB skin
Although
test.
if you're in Japan, they measure the redness.
Really?
Yeah. See, the only country I'm aware of in the world that measures the redness, but that's what they do.
Uh, yeah, just more evidence that this isn't a great test, basically.
Yeah. Well, I mean, it turns out the redness correlates with the bump, but it also turns out the bump is more specific than the redness. But anyway, that's kind of the deal. But
Okay, so a little bit about prior positive TB skin tests or IGRAs, especially in the healthcare setting. You really need to have documentation of the positive test result for the healthcare worker and a negative chest x-ray. If you have documentation of those positive results, you don't need to really repeat the TB skin test, IGRA, or chest x-ray. Just screen the person for the signs and symptoms of TB. But documentation is critical. If you don't have the documents, you need to repeat the test basically. There are a couple of exceptions. If you're going to treat the person for LTBI, you might want to get a new IGRA just because they've gotten better as time has gone by. And everybody should get a new chest x-ray before starting LTBI treatment. Or, of course, if the person has symptoms of TB disease, you want to get a chest x-ray and maybe also sputum. So, about administering the TB skin test, just a couple of little quick tips here. Don't drop the solution more than a half hour before administration. And, don't place the TB skin test on bumps, scars, anything like that. And a critical point is you need to be able to try to produce a wheal of at least 5 millimeters and don't put a Band-Aid on it. Now, I have to say, I've administered a lot of TB skin tests back in the day, and there was absolutely times I just could not get a wheal. So you just need to do the best that you can. And even if you don't produce a wheal, sometimes you'll end up with a positive anyway. So what if something gets messed up, and it certainly happens with the placement? If there's no wheel or it's just fluid leaks out, go ahead and repeat it on the other arm. And you can do that right away and just document where it's placed so you remember to read it correctly. Okay, a bit about reading the TB skin test. It needs to be read 48 to 72 hours, more or less, after it's placed, or up to 7 days if it's positive. The patient cannot self-read, not acceptable, even if the patient happens to be a healthcare worker. You want to measure across the arm, that's transverse, and record in millimeters, even if it's negative. And again, in the US at least, we measure the induration or the bump and not the erythema or the redness. So just a couple of tips are right there on the bottom. If you're still not sure, you could look again the next day. Sometimes the TB skin test gets bigger as time goes by, but I usually just say if you're not sure, go ahead and test them with an IGRA. So again, this is correct measurement and a wrong measurement. And I'm just emphasizing this because we still see measurements done incorrectly, unfortunately. So sometimes, as you might guess, people don't show up in time for their read. We usually say that, you can give or take 4 hours in the 48 to 72 hour range. If there is no reaction and greater than 72 hours, unfortunately, you're going to have to repeat the test. Just go ahead and place it on the opposite arm and again, document that you're looking at that arm. So in healthcare settings, a two-step TB skin test is required for new hire screening. I still encounter some healthcare facilities that have gone, a long time without doing two-step tests. They thought only one test was needed, so I thought might be worth mentioning here that it needs to be a two-step TB skin test. Here's a little flowchart describing how that's done, but also feel free to ask questions. Okay, maybe I'll take a little pause. Any questions so far?
I have a question. Does anyone still use the skin test? I know corrections does, but does anyone else in the chat use it at the health department level or? Looks like some counties do.
Yeah,
More.
it looks like Morrow County still uses it. Someone says, yep, when we hire employees, we do a two-step
Yeah.
test, nursing homes.
Yeah, cool. Yeah, I mean, as you guys know, if you're gonna use it, you got to keep the training up in terms of, placement and reading. It's hard to do, and If you get new hires that haven't done it before, you really got to make sure they get good at it. So.
It's true. Yeah. I see a question too. I thought you said healthcare workers didn't need to do the LTBI skin tests anymore. Okay, yeah, I should clarify that. Uh, Annual screening is not required for healthcare workers anymore. Baseline new hire testing is still required. So when you hire a new employee into the healthcare environment, they need to have a two-step TB skin test or a single IGRA. Is IGRA better than TST? Kevin, you want to take a crack at that one?
Yeah, it is better.
That was easy.
I mean, we're going to review some of the information here in a sec. So I'll answer more as we go on the IGRA.
Yeah, thank you. Okay, moving along here. Criteria for positivity with the TST. So I'm not going to read all of this, but do know that there are different criteria, especially for contacts, right? A very small little bump is a positive for contacts. Also, we have all these people that are in the 10 millimeter or greater range. And then in Oregon, I don't think 15 millimeters would really apply because hopefully everybody you're screening is at risk. So even for healthcare personnel, the cutoff really is 10 millimeters for a positive TB skin test. Okay, quick question. Just you can think about this on your own. In your setting, do you ask questions to determine risk factors and immunocompromised status? This is something we really recommend you do before testing anybody for latent TB infection. Okay, so unfortunately, with the TB skin test, there can be false negative results. So, again, like we talked about, if the person has active TB disease, sometimes the TB skin test is falsely negative. If anything is affecting their immune system, it can also affect the TB skin test result, and you could end up with a false negative. Also, of course, if you don't store the tuberculin correctly or you don't place the test correctly, you could end up with a false negative. So, one of the bigger bummers about the TB skin test is you can also get false positive results. This can be related to non-tuberculosis mycobacterium like M. avium. Uh, Common wisdom is usually the reaction might be smaller, but who knows? Also, BCG vaccination could create a false positive TB skin test. And sometimes people might have a slight allergic reaction, but that should ideally go away. Kevin, anything you want to add to this about false positives?
Not really, other than that's the whole reason, of course, we have the quantiferon is that there were too many false positives with skin tests, mostly driven by BCG. There's a lot fewer false positives in the absence of BCG, but they do happen. And of course, the lower your cut point for positivity is, the more likely the positive is going to be false, right? A 5 millimeter reaction versus a 15 millimeter reaction. So that is inherently the difficulty with the TST and why we have those different levels of positivity, because it's all based on positive predictive value, which is based on risk. So seeing in the chat there question about why do you need to do the questionnaire even if you're screening with an IGRA or a skin test, and the reason is it all comes down to predictive probability. It's just Bayesian, right? It's a priori probability. It's positive predictive value. So the chance that either one of those tests, if they're positive, the chance that they're actually truly positive is totally driven by person's risk factors. So if you get a positive test in someone who shouldn't have a positive test, like they were born in Salem and they haven't left their parents' basement yet, then it's going to be a false positive. So it's important to take that history. If their history was, they were born in Vietnam and just came here 3 years ago, it's much more likely to be a true positive.
Yep. Very good. Yep. I see another comment. I've understood that the BCG given as child does not really affect QFT results. Um, oops, sorry, something happened there. I lost
Yeah,
track of
yeah,
it.
no, that's true. I mean, BCG doesn't affect QFT at all. There are a few NTM in the environment that affect the QFT, but they're relatively rare, rarely encountered and uncommon, particularly up here in Oregon. So it's not something we really worry about.
Yep, exactly. Agree. Yep. Thank you. Okay. All right. So when you do a TB skin test and you read it, you have to document quite a bit. Um, this is all the stuff that you have to document. And then when you read the result, it's critical that you record the result in millimeters and then you record it as positive or negative. So an example could be a 2 millimeter negative. So also give a copy of the result to the patient, especially if it's positive, and tell them to not lose it because we don't want to keep retesting people who are persistently positive. So give them a copy. If you check that QR code there, I believe that you will get a link to let me see, a link to a document that you can use to give to your patients with the result. All right. So here's a little question for you to think through. A patient comes back for his TB skin test reading. He tells you he was moving this weekend and had to carry some boxes. It messed up his TB skin test. You looked at his arm and it looks something like this. What do you think of this result? What might you do? Right. I see repeat the test. That's a good answer. Um, measure and record per criteria. Uh-huh. Okay. Blood test. Yeah. If it was me personally, I think I would probably go ahead and give this person a blood test. Um, the reading, it looks like it's probably a positive, but he's already telling you that he doesn't believe it's a positive, and it could be a little bit difficult to read. So I would probably follow up with one of the IGRAs. What do you think,
Uh,
Kevin?
I totally agree. I mean, the nice thing is we have both of these tests now, two methodologies. So in the old days, you didn't have that luxury. So it is nice to use the other one if you don't believe if you don't believe this one or it's not interpretable, it's nice you have another methodology. So I agree. I agree.
Yeah. I see another question in chat. Is it wise to follow up a positive TB skin test with an IGRA test if they don't have any risk factors? Yes, I think yes.
Yeah, I agree because that's the kind of person you're thinking it's probably a false positive. They have no reason to have this. And of course, if you get the IGRA and it's positive, then you're going to be much more likely to believe it. So
Yes. Yep. All right. So an IGRA or a TB skin test or both. So IGRAs are preferred when the person is likely to be infected and they're low to medium risk for progression. If they're so that would be like screening people who are foreign born or during a contact investigation. IGRAs are also preferred, say, for people who are unlikely to be infected, such as, healthcare personnel screening, and definitely for people who are BCG vaccinated. The TB skin test is preferred only really for kids under the age of 2, and even that is a little bit controversial at this point. IGRAs may work for kids under 2 as well. Sometimes we like to recommend both results are used if the result is really critical, say the person is immunocompromised or something like that. Oops, and neither result is very reliable. You might want to use both. Or if the interpretation of the TB skin test or IGRA is just unclear, like that example we just talked about.
yeah, and I just weigh in to say that it really is. If you want to maximize your sensitivity, the most sensitive way to do this is to use a skin test, and then if it's negative, followed up with an IGRA 3 days or more later, because the skin test will sensitize, or increase the sensitivity of the IGRA in someone who's actually truly infected. It won't do so in someone who isn't infected, but if they actually are infected in the skin test, it will kind of help wake up their lymphocyte responses, so to speak. So, there are outbreaks or CIs sometimes, like a classic example would be a dialysis center where these people are immunosuppressed, they have energy, they're much more likely to be falsely negative to the skin test and the IGRA. Maybe it's a better idea to use both. And it is a better idea. Again, it maximizes your sensitivity. So that is something to think about in very select situations.
All right. So moving on to a little bit more about IGRAs. Any last minute questions before we move on here? Let's see. Oh, okay. I work for an ambulatory surgery center. Is it okay for a new employee to start working on the floor while waiting for the TB blood test result if the TB symptom questionnaire indicates no risk factors? Yes, absolutely. Yeah, they can go ahead and work. All right, so the IGRAs. Um, like we said, good thing about the IGRAs is they're not affected by the BCG vaccine or most non-tuberculosis mycobacterium. There's two types. There's a quantiferon plus, quantiferon plus, and also the T-spot. T-spot is some people find a little bit easier to use just because you only need to draw blood into one tube, and there's not as many issues with getting it to the lab. The time frame is longer. Results are just positive, negative, or borderline or equivocal. And it's mostly, I think, or only available right now through Quest Diagnostics. Quantiferon Plus, there's a variety of tubes. Kevin, do you want to talk a little bit about the tubes and what they mean?
Yeah, so this test came out, I don't know, this version came out 6 or 8 years ago. And what they did is they introduced a second tube. So the first tube does kind of what the old test does, is it takes a couple antigens that are specific to TB, ESAT6 and CFP10, and basically measures your lymphocytes recognition of those, right? So if your lymphocytes have seen those things before, and I'm talking about CD4 T lymphocytes, they dump interferon gamma. You measure the interferon gamma. And if it's above the threshold, then you call it a positive test. The second tube, the idea was if we measured CD8 responses, which is another type of T lymphocyte or T cell, that maybe you'd pick up more active TB that way and might help overcome the false negative issue in the face of active TB that we were discussing before. So in that tube, it's actually meant to measure CD8 and CD4 responses, both of them. And they put an extra peptide in that tube, which, basically it's a proprietary peptide. I don't even know what it is. Nobody does know what it is, but it's a peptide that is from TB. And so your CD8 T cells and CD4 T cells will see it. If they know it, they'll again dump interferon gamma. So TB1 tube is measuring those CD4 cell responses. TB2 is measuring CD4 and CD8 responses. So I mean, theoretically, TB2 tube should always be the same or greater than TB1, although that doesn't always happen, but that is kind of what should happen. And it's kind of a 2-for-1 deal. It's two tests in one. So if either one's positive, you accept it as a positive. I can tell you if they're both positive, then I'm very convinced that it's real. If just one's positive, I'm a little less convinced, but that is a positive test by the product insert and by the testing, by the data. But again, it all boils down to that risk factor equation, the a priori risk. So.
Okay, so like we said, there's 4 tubes for the blood draw. So I should mention that depending upon what lab you're sending this to, you may only need to draw the blood into one tube, and they might split it out into 4 tubes in the lab. So it kind of depends on whether or not you're actually doing it when you draw the blood into 4 tubes on the lab that you're using. But anyways, appropriate shaking is really important. If the shaking isn't done correctly, it could lead to problems with the results. So that's something to be really mindful of. And then also it's important to get it to the lab within the appropriate time frame, which is a little bit narrow. So you get qualitative results, which are positive, negative, and indeterminate. And then you get the quantitative results, which is what Kevin was just speaking to.
Yeah, and the higher it is, the more, the more positive it is. So certainly the ones that are right near the borderline are much more likely to be false positives. If they're way above the borderline or the cut point, then they're much more likely to be true.
All right, again, just do a risk assessment for everybody so you can help determine whether or not you have a false positive result. And if you're skeptical at all, we always just say go ahead and repeat it unless there's a high risk for disease progression. Okay, quick question for us to think through. You test a patient with a quantiferon test. When she comes back for the results, she brings documentation of a positive TB skin test, but the quantiferon result was negative. Why might this happen?
Well, because the skin test isn't very good. We talked about false positives, with skin tests. So there's a lot of reasons out there. I mean, I used to say, oh yeah, you can get positive skin tests just by, breathing or something. But there are people that will have positives on one arm and negatives on the other arm. So in the same person at the same time. So you just see false positive due to probably mostly environmental bacteria that was mentioned before, in addition to BCG. So.
Yep, exactly. Yep. Thank you. And I saw somebody had put BCG in there in the chat too. So very good. All right. TB case studies, special populations that might be tested. Let me make sure we're in the right place. Okay, yeah. Okay. Kevin, you want to run through this one?
Yeah, I'll do it. This is a drug that you see advertised on TV all the time, like 10 times per hour, it seems like it, particularly if you watch the news on TV, which I'm not sure anyone does, but Rinvoq is the name of the drug, or upadacitinib. This is a class of drugs called JAK inhibitors that have become really popular the last 5 years. And they inhibit what's called Janus kinase, or JAK. And there's four of these receptors or kinases that facilitate extracellular signaling through the cell. And so the big deal is they facilitate interferon gamma signaling. So of course, interferon gamma is one of your body's biggest ways to turn on cells to kill TB. And if you shut that signaling down, then of course, you can increase the risk of TB. So that's what these drugs do. They're very similar to TNF blockers in terms of the risk of TB. So anyone who's starting them should be, of course, screened for TB. So this is a patient with rheumatoid arthritis who came from Thailand, so a high risk area 10 years ago. And they've also been on prednisone. I didn't put the dose there, but it's important to think about the dose. And they're switching to this new drug. So of course, will you test this patient for LTBI? Of course, I already answered the question, yes. And then how will you proceed? So we'll go to the next slide. I mentioned this. The other ones are tofacitinib or Xeljanz, or baricitinib Olumiant. Baricitinib became very popular in the pandemic because we started actually treating people with COVID with baricitinib because it tamed down the immune response that was so aberrant and causing people to die from COVID. But those are the drugs: rheumatoid arthritis, inflammatory bowel disease, ankylosing spondylitis, psoriatic arthritis. There's a long list of conditions: alopecia, atopic dermatitis. There's a number of autoimmune conditions where these drugs are being used, and they're oral. So anyway, that's the issue there. Next slide. I put kind of all these drugs up here because not to overwhelm you, but we could spend the rest of the hour just learning how to pronounce the names of these drugs, and I've done that before with audiences. But up above, the TNF blockers are the ones you're most familiar with because you've seen those Infliximab or Remicade is the drug you'd know, or Tanacept or Enbrel, and adalimumab or Humira. Those were kind of the big three and the three most popular. Now there's all sorts of biosimilars of these drugs too that are running around with names that you can't pronounce either. The other biologics that are out there, I mean, these are very common drugs now. I mean, they're being used in probably up to 5%, 5 to 10% of the population, even maybe 5%. But again, for the conditions I mentioned, before, the ones I put in pink or blue there, whatever that other color is, those ones don't really cause TB. And these ones are used in psoriatic arthritis mainly, or psoriasis. They don't seem to increase the risk of TB or really infections at all. And the IL-17 blockers right below that, I would put also in that category. They're also psoriatic arthritis or psoriasis drugs. But the IL-6 blockers, B cell inhibitors, abatacept, JAKs, and TNF blockers, they all increase the risk of TB. And so by and large, everyone who's starting one of those drugs needs to be screened. And even the drugs I just told you that kind of don't cause TB reactivation, most of those people are going to be screened anyway, because a lot of times the product insert says to screen them. Next. So, this would be someone at high risk. You'd use a 5 millimeter cut point if you're using a skin test. Again, most of these people have conditions where false negative skin tests would be common. I would use an IGRA because it is more sensitive than a skin test, particularly in immunosuppressed patients. You can definitely have false negative IGRAs in immunosuppressed patients as well, but it probably happens to a lesser extent than the skin test. The risk factor assessment is, of course, key, and of course, excluding active TB if they have a positive test. So that would mean a chest X-ray, generally speaking. So in terms of if you do diagnose them with LTBI, you can start their treatment for LTBI, which we're going to talk about in a few minutes. You just need to start it before you start the TNF blocker or the JAK inhibitor or whatever immunosuppressant they're using. It doesn't have to be a month earlier or 3 months earlier, whatever. It can be almost basically concurrent, but it just has to be before. We usually try to start the TB treatment a week before the immune modulator, just so we are making sure that they actually picked it up and they're taking it, that kind of thing. Next. Okay, we'll go to TB case contacts. Heidi, you want to talk about case contacts?
Sure. Sure. So you'll see the QR code there. That is a link to the CDC guideline on contact investigation, and it'll have quite a bit more detail. Again, this could be a whole presentation in itself. So first of all, you have to figure out who is a contact, and that can be complicated. So we try to take into all of these factors, including how infectious the case might be. Are the contacts immunocompromised? Where did the exposure occur? For example, say it was a nurse who was intubating a patient, that might be a high risk exposure, say. We look at the space size, and then we look at the length of exposure too. So for contacts, you want to test them right after the exposure and then 8 to 10 weeks later. We really prefer an IGRA, but a TB skin test is acceptable for a contact investigation. Just make sure you stick with the same testing method post-exposure and then 8 to 10 weeks later. Okay, so contacts less than 5 years old and window prophy. So again, there's the QR code. You can look at the details, but in general, people who are really highly immunocompromised, and in particular, kids less than 5, are at very high risk for progression to TB disease if they're exposed. So our process is a little bit different. What we recommend is a TB skin test or an IGRA, and then a 2-view chest X-ray and medical evaluation, regardless of the TB skin test or IGRA result. So even if it's negative. If the chest X-ray and medical evaluation are normal, you still go ahead and start LTBI treatment using INH or rifampin. And then you do a retest 8 to 10 weeks later, and you stop window prophy if the retest is negative and the child is more than 6 months old. There are some medical providers who might choose to complete LTBI treatment regardless of the result. And again, the reason for doing all of this is just because little kids are highly immunocompromised. Okay, any questions so far about window prophy or anything else? I don't see anything new in chat. All right. Contacts who were previously positive by TB skin test or IGRA. Again, we want to make sure that that positive result was documented. If they've never completed treatment, now might be a good time to offer it again. If you're going to retreat them, make sure that they get a chest x-ray, a new chest x-ray. If they were treated previously, for the most part, you only need to do a symptom check. Unless, again, the individual is highly immunocompromised, then we might consider retreatment. Okay, here's a question to think through. You're referred a TB contact. She lives with the index case. She's diabetic and has documentation of a positive TB skin test, normal chest x-ray, and completion of LTBI treatment with 9 months of INH in 2001. You could put your answer in chat if you want, or just think about it. Which one would you do? Retest her with an IGRA and treat her again if positive. That's one. Or start by getting a new chest x-ray. If negative, nothing else is needed. Or three, start by assessing for TB symptoms. If asymptomatic, nothing else is needed. So I'll give everybody a second here to think through it and put your answer in chat if you like. Okay, so typically if somebody is diabetic, they might be somewhat immunocompromised, but usually what we do is if they've been treated for LTBI in the past, we don't retreat them. We would just usually start by assessing for TB symptoms, and if asymptomatic, not do anything further.
Yeah, I just say it's a tough situation, and sometimes we run into this with like really immunosuppressed people, like beyond diabetes, and I'd say every once in a while we do just retreat someone, given that we think the exposure was so great and they're immunocompromised, they may not be able to handle exposure. And I will say shorter course for FAMPA-based therapy is a big win here because you feel a lot better about treating someone for 3 months, for example. So it is something to consider. And if you need to get a consult, ask someone like me or IDE, Palm, someone who has a TB experience to think about this for you.
Yep, exactly. All right, so moving along to treating LTBI. Any questions before we move on about diagnosing LTBI or contact investigation or anything else? All right, doesn't look like it, so we'll go on to treatment. So sometimes people are going to ask, what is my risk for developing TB disease? And it really depends on when you were exposed and your immune status. If you were just recently exposed, your highest risk is the first 2 years after your exposure. So that's why we spend a lot of time on contact investigation because of that very reason. However, those with LTBI who are HIV negative have about a 10% risk over their lifetime if their immune system remains intact. So relatively low risk, but still there's a risk. So before you start LTBI treatment, you need to be absolutely sure you rule out TB disease. Do they have any symptoms? You'll need to get a chest x-ray. For an adult, a PA should be sufficient. For a little kid, usually we recommend a PA and lateral chest x-ray. Sometimes people just have had chest x-rays relatively recently, so you're wondering how old is too old? Can I just get by with this? For the most part, if it's not more than 3 months old, it's okay for most people. But if the person is really immunocompromised, if the chest x-rays say is older than 1 month old, you'll probably want to get a new one. Okay, before starting LTBI treatment, we really recommend a physical evaluation, especially for kids. The pediatrician will want to look for things like failure to thrive, enlarged lymph nodes, things like that. And then you'll want to get any information that you can about previous treatment for LTBI or TB disease. Do a good assessment for liver disease, regular use of alcohol or drugs, HIV, pregnancy, or if they are immediate postpartum. If there's any risks, you want to get LFTs or CMP prior to starting treatment. So sometimes it can be hard to decide whether or not to treat somebody. There is no age cutoff, so older people can be treated. And really, what you want to weigh is the risk of disease progression versus treatment toxicity. And luckily, with now the shorter course regimens, there's less risk of toxicity. So I think we tend to probably treat people more often than we used to. All right, talking about treating some special groups of people. LTBI treatment and kids. So we really like to push treating kids for latent TB infection because they have a high lifetime risk for disease progression and also maybe a higher risk just because of their age and being immunocompromised due to that. Our preference is rifampin daily for 4 months or INH and rifampin daily for 3 months. Any age can take those regimens. 3HP, which we'll talk about a little bit more in detail, is okay for kids that are 2 years old, but we usually recommend it's done with directly observed therapy. Finally, INH for 9 months is an alternate, but again, that's a long course of treatment. The dose for kids is weight-based. Liver toxicity is possible, but it's rare. INH can be made into a syrup. Rifampin sometimes can be made into a syrup by a compound pharmacy, but generally we recommend avoiding syrups and trying to go with crushed pills because the syrups can cause stomach cramps, diarrhea, and other problems. For kids, you don't really need to use vitamin B6 unless it's an exclusively breastfed infant. Okay, so quick question. A pediatrician calls you. They're caring for a 1-year-old who is a TB skin test positive boy from Mexico. The PA and lateral chest x-ray are normal. What is your recommendation or how might you work through this? More than one answer could be correct. So you could refer the pediatrician to Curry Center Warm Line. Dr. Loeffler used to be a TB pediatric expert in our region and she was often took these kind of calls. Or you could go ahead and treat with 3HP or rifampin daily, or get an IGRA, or test the boy's parents. So which of these do you think might be right? Or what would you do? You can put it in chat or just think through it, whatever you prefer. All right, I'm going to put Kevin on the spot. If it were you, what would you do?
I'd call Ann because I miss her.
Why not?
She's great. Yeah, I mean, I think, it's hard to know because the kid probably had BCG very, not too long ago.
Yep.
And it may be that you just want to get an IGRA and see if it's positive too. I mean, if they're really infected, it should be positive. The problem is, they're one, and the IGRA is not that sensitive, and neither is the skin test. So it's a shared decision-making call. And if they have no TB history in the family or no known contact, you might just want to give it some time and repeat a few tests, or you just might want to haul off and do number two. I mean, number two is easy, it's cheap, and it's well tolerated. So it's hard to argue against just treating the kid for 4 months with rifampin.
Yep. Agree.
What would
Tricky.
you do?
I'd probably get an IGRA, I suppose.
Yeah, I think I get IGRA no matter what. It might, because if it's positive, it's certainly going to push you into treating. So it could be helpful that way anyway.
Yeah. Yep. And if you're able, it's also a good idea to test the child's parents. It's not required or anything like that, but it's a good idea.
Yeah, there's no right answer here other than all these things are pretty reasonable to do.
Yep, exactly. Okay, LTBI treatment during pregnancy. Kevin, do you feel like rolling through this one?
Sure. we've always kind of had this mantra of, deferring any sort of therapy until 3 months after postpartum, unless the patient has really a high risk for progression. They're really immunosuppressed, like HIV positivity, or they were just a contact to an active case. In those cases, you want to just go ahead and treat them. But the whole 3 month thing, I mean, this is all holdover from INH toxicity. So, when we did this, I was part of the CDC team when CDC used to be able to do work 20 years ago. And we evaluated all the INH hepatotoxicity cases in the country. And there was definitely association with it being more likely to occur among pregnant people or recently pregnant people. It was much more likely to occur in the first 3 months after pregnancy. So it became the mantra, and again, this is just an observational study, but it became the mantra to go ahead and start treating after that 3 month period. And again, this was back when all we had was INH. I don't necessarily think there's any data saying if you're using rifampin that you need to wait till 3 months postpartum. But I think by and large, it's pretty easy. Just in general, right? We try not to do things to pregnant people that we don't have to do for obvious reasons. So I think holding off at least until the baby's born, then you could probably just start treatment whenever afterwards. But if it's INH, I'd wait the 3 months.
Yeah, sounds good. Yep. Okay, LTBI treatment in older people. Kevin, you want to roll through this one too?
Yeah, I mean, this is kind of tough because a lot of old people are like, they're so old, I don't want to do this, or that's how they feel. And, when you had to put someone through 9 months of INH and risk hepatotoxicity, that's how you generally felt too. You're like, wow, I'm not going to treat you. You're 80. You're just going to get your ALT to 400 and we're going to have to stop. So, the advent of short course rifampin-based therapy has been huge. So 4 months of rifampin or even the once weekly 3-HP, which combines INH and rifapentine. I mean, either one of these has shown to have a lot less hepatotoxicity than 9 months of INH. So it's kind of just opened up. There is no upper age limit anymore. There used to be kind of this 55 or 60-year-old idea as an upper age limit for INH when we were using it alone. But nowadays, there is no upper age limit. And certainly people who have immunocompromising factors, diabetes would be really common, renal failure. I mean, these kind of people you end up probably treating anyway, as long as you can. There are some issues with drug-drug interactions sometimes that preclude the use of rifampin. So it may be more difficult, or maybe you're not going to treat a 75-year-old on Eliquis for their, AFib, because Eliquis and rifampin interact, and you don't want to mess this up. So there are some people you won't be able to treat with shorter course therapy, but in general, older people who have risk factors for reactivation, you're going to go ahead and treat them.
Okay. You can just think through this, everybody. You are working with a family that are refugees from Syria, and go ahead and put in chat what should be done for each patient in your mind. You have a female who's 42, quantiferon positive, pregnant in the second trimester, a male who's 45 years old, QFT negative, and then a child who's 40 or 4 years old, TB skin test positive, 12 millimeters. So go ahead and think through it, and I'll give you a minute, and then I'll just quick roll through the way I would think about it.
While folks are thinking about that, Fran wanted to know, Kevin, what is old, quote, old? What would we consider old in regards to what you were just discussing?
Oh, how old is Fran?
I'm not asking Fran that question.
Well, old is pretty old. I mean, I treat 75 and 80-year-olds sometimes because they've got clearly have latent TB and they have diabetes, or they're going on prednisone, or they have rheumatoid arthritis, or whatever it is. They have risk factors for immunosuppression, so I treat them. A healthy 80-year-old with no risk factors who was exposed, 40 years ago, I probably wouldn't treat that person, because at that point their risk is really, really low. But so again, there's no cutoff for age, and old is in the eyes of the beholder, I guess,
Agree.
in terms of a definition.
I know Fran sees a lot of B waiver immigrants, so that might be partly why she's asking her question.
Yeah.
So, all right, back to our family here. Okay, quantiferin positive, pregnant, second trimester. Again, you could wait until the patient delivers her baby and then treat about 3 months postpartum, or you could consider using rifampin, probably not INH if you're going to treat her while she's pregnant. Also, of course, you will want to get a chest X-ray. Let's see, second trimester, you might want to do a shielded chest X-ray if you're going to go that route. Did I get that right, Kevin?
Got it. Yep.
Good. All right, 45-year-old male, quantiferon negative. Maybe don't need to do a lot, although if they just arrived in country straight from Syria, you might want to retest them with another quantiferon in 8 to 10 weeks, because again, we have that window period. Our 4-year-old who has a TB skin test positive, 12 millimeters. Again, if they were BCG vaccinated, you might want to consider getting a quantiferon test for them to be on the safe side. All right, rolling through our LTBI treatment regimens. So here is a summary of the various options. Okay, LTBI treatment with rifampin, also called affectionately 4R. I like to recommend this regimen. I find most patients tolerate it pretty well, but it consists of 4 months of daily rifampin, 600 milligrams every day for a total of 120 doses. It's really appropriate for kids of just about any age. The biggest problem, I would say, is drug-drug interactions. So you really need to do a careful check. Rifampin can interact with many things, including birth control. Kevin, do you want to do a little quick spiel on birth control? Because I get a lot of questions about that.
Yeah, birth control is good and it's important. So that's my quick spiel. You don't want to mess it up. So daily rifampin could potentially mess it up. I think once a week rifapentine, which you'll talk about, is probably unlikely to mess it up. But there is some drug-drug interaction, particularly with the estrogen components of those pills. So I think if I had a daughter, on oral contraception using rifampin, I would tell that person to use a second form of birth control during that 4 months. I think it's unlikely. I mean, I haven't heard of anyone. I've never had a patient get pregnant while doing this, but I think it is theoretically possible. So the risk would be elevated.
Yeah, I think we've seen problems too with people who maybe are on methadone is another one I remember.
Yeah, absolutely. I mean, pain control, opioids. Look, whenever there's like big drug-drug interactions, I try to use the once weekly just because the rifapentine is going to interact for a day and a half of the week, and the rest of the week you're going to be fine with your methadone. Um, but if you have to use this, I mean, this is the simplest, cleanest regimen that has basically no hepatotoxicity. It's really, really just a drug-drug interaction issue. So, hypertensives, usually you can overcome it by increasing the dose of the antihypertensive. There's some things like Eliquis, you can't. I mean, a lot of people are on Eliquis now and drugs like it that are, blood thinners, antiplatelet agents, or people with AFib or people with a history of DVTs, things like that. Those meds are becoming pretty ubiquitous, and you can't use rifampin at all with that. So there is a short list of drugs that you just can't overcome an interaction with, and you really just shouldn't use it.
Which brings us to our other preferred option, which is 3HP. Kevin, do you want to talk about this one?
Yeah, I mean, I'll just keep waxing on here. The big problem with this regimen is it's a buttload of pills, and most adults are going to be 3 INH pills and 5 or 6 rifapentine pills. Someone needs to just reformulate the dosage so that it's, 1 pill each, for example, or a combined pill. It's just one. But so some people look at 9 pills and say, "Oh, geez, this is, ridiculous." I try to then just counsel them like, "Look, man, they just made the pills too too small because they were making them for other things. They didn't realize it's just the newer pills coming out next year or sometime that they'll have the dosage corrected. So it's not like you're taking extra medicine just because you have a large number of pills. There are some people that get kind of fluey for the 24 hours. They take the rifapentine, I'd say about 15%. And then like I said, there is this issue with drug-drug interactions, but again, it's only going to happen while the rifapentine's active, which is about 36 hours. So usually it's an issue that can be managed. It's not an issue with drug-drug interactions. The other thing too, just to mention, is you have to be organized. So it's like someone who's got a pill box, someone who can set their iPhone up and actually respond to a notification. I mean, somehow you got to remember to take it the same day each week for 12 weeks.
Thanks. So completing 3-HP, you need to get at least 11 doses within 16 weeks, and the doses need to be at least 72 hours apart. We don't want any big treatment interruptions on this one because, it's only once a week.
Yeah.
Okay, another option is isoniazid and rifampin for 3 months. And again, this is a preferred regimen. I don't recommend it often, but I think it's probably pretty well tolerated and yeah, a good one. What do you think, Kevin?
Yeah, I use this all the time. I think it's pretty well tolerated. There's less hepatotoxicity with it than 9 months of INH. It should work as well as the 12-week regimen you just outlined. So this is a reasonable way to go. I mean, why would I add the isoniazid to the rifampin? Right? Why wouldn't I just use rifampin for 4 months? The reason I would choose this sometimes is the reason, like you and I both trained in California. I mean, sometimes you hedge a bit and you don't think they have active TB, but there's a little part of you that worries they do, even though they've ruled out. And then I kind of hedge and put them on INH rifampin for 3 months. I mean, that's generally the reason I use this regimen.
Okay, so just a few reminders about rifampin and rifapentine. Unfortunately, more than once, I've found a medical provider who has confused rifampin with rifapentine, and then they put their patient on some regimen that just doesn't make any sense because of that. So make sure you're not confusing the two. Remember, there can be drug-drug interactions like we talked about. Also, the tears, saliva, and urine can be stained an orange color. Definitely that will happen with urine. It's possible it could also stain contacts and dentures. Hepatotoxicity is possible, but less than with INH. They still should probably have baseline LFTs if at risk. Also, thrombocytopenia is possible. So some clinicians get CBC prior to start, but you do want to watch for easy bruising and things like that. Anything to add, Kevin?
Nope, that looks right.
Cool.
We have a question in the chat if these meds can cause resistance.
Nope.
Yeah, as long as you rule out TB disease really well beforehand. Yeah.
Yeah.
Yeah, it could cause drug resistance if the person had TB disease and you only treated them with one
Yeah,
drug.
if they have active TB and you mess up, that's kind of why I was saying sometimes I do the INH rifampin combo just as a hedge against the possibility they might have active TB. But again, as Heidi said, you shouldn't run into resistance. So.
No. Okay, INH, it's not a preferred regimen anymore. It's an alternate. So we're not going to spend a lot of time talking about it, but you would want to add vitamin B6 if there's a risk of peripheral neuropathy. Baseline labs are not really routinely indicated, but some people do get liver function tests for everybody. Let's see, we'll skip this one. Okay, moving on to talking about side effects, which can be relatively common. So in general, it's always fine to tell a patient to stop treatment while you figure out what's going on. These are a list of some possible side effects people can have. In doubt, just stop it. It's not hurt the patient at all. Just wait for your lab work to come back. No, the patient will develop drug resistance if you just stop for a little bit, the doses on to the end. So you want to try to see the you want to make sure they aren't, try to figure out why, symptoms of hepatitis or other side effects that might be occurring. So elevated LFTs can happen, especially with isoniazid. It's possible also with rifampin, but less likely. With INH in particular, some elevation is probably expected. So what we recommend is you look for a reason for it, alcohol use or anything else, get a hepatitis panel if necessary. Most of the time, we don't really see it problematic unless it goes 3 times upper level, but you could always consider switching to RIF if you can. GI complaints, I think, are pretty common. What do you think, Kevin?
Yeah, they are. And I usually have people take their meds with some food. And I think some of the GI stuff is much less likely to occur. So I know pharmacists will tell you to take rifampin on an empty stomach, but that's not true. You don't have to. And I generally don't tell people to do that.
Yeah, I had the pleasure of taking INH for 9 months back, way back when. And I think the only reason I got through it was I took it at night because it always upset my stomach. So, yeah, just do some problem solving and hope they can get through it. Or if they,
Take it with ice cream. That's what I always say.
yeah, no one's going to complain about that. Okay, side effects. Some people might get a rash if it's, some minor itching. You could use some antihistamines, lotion, and carry on. If they can't tolerate it, you could switch drugs. We worry about something like a petechial rash because it could be thrombocytopenia if they're on rifampin. So I do want to check platelets. If the platelets are low, then you might have a rifampin hypersensitivity reaction, and rifampin would absolutely need to be stopped. Any other thoughts about rash, Kevin?
No, other than I try to usually treat through the rash at the very start to see if I can, get it to go away with some topical steroids or even a short course of oral steroids. But oftentimes it just doesn't work. But I do often try to do that. Sometimes it gets better and you get through it. It just depends if you have other options and how convinced you are that it's related to the medication. So.
Peripheral neuropathy is really just mostly related to isoniazid, and it could be due to a lack of B6 absorption. So you'd want to start B6 if they're not already on it. You could increase the dose if they're on 25 milligrams to 50, but don't go any higher than 50 milligrams. Again, consider switching regimens, and it's generally reversible.
Yeah, I agree.
All right, completing treatment. So a lot of times we'll find patients miss doses or just plain disappear. So when they come back to you, you want to make sure they can commit to the treatment. If they don't want to take it, that's okay. They don't have to. Maybe later on in their lives, they'll be more able and willing to do it. So, do a little bit of discussion with them. Are they on board? In general, if the interruption is longer than 2 months, we recommend you rule out TB disease and probably you need to restart treatment, unfortunately. If they just miss the occasional dose, you just extend treatment to include those doses so you get the right number. So this is basically how many doses you need in order to complete LTBI treatment with each of the regimens. Okay, quick couple FAQs that I get anyway. Is LTBI reportable? What happens if somebody refuses LTBI treatment? It's not a reportable disease in Oregon. It is in some other states. But because the person is not infectious, in my mind, they can absolutely refuse to take treatment. Just advise them to seek medical care if they develop TB signs and symptoms. Another one that happens a lot, patient left unexpectedly while on LTBI treatment. She's been gone for about 3 months. What should I do? Usually at that point, you're going to need to restart them, unfortunately. Get a new chest x-ray and consider using the shortest regimen possible, which is probably 3 HP. Let's see, another one. Sometimes we run into problems with rifapentine. The pharmacy was out of rifapentine, which happens. This is a drug that sometimes goes into shortage. And the patient accidentally just took INH weekly for a month. What should you do? You might need to again start treatment over from the beginning, unfortunately. Okay, so here are some materials and resources. I think we emailed everybody the PowerPoint, but you also have the QR codes there. And here are just your resources. This is information on how to contact me by phone or by email. Another good resource is the Curry International TB Center. They also do consultations. They might be a little slower than Kevin and I, but they will help you. Yeah, and so I think that brings us to the end. Any questions from anybody? If you want, you can remove yourself from chat, from mute, and ask questions or put them in chat. Anything else you want to mention, Kevin?
No, other than just feel free to reach out. I mean, I think those were some common questions we get that you just went over. And just said, I think if you don't have to monitor as much with the rifampin-based regimens, from a lab standpoint. So that's important to consider. I often check people's labs kind of halfway through the 12 weeks or halfway through the 2 months. But again, you really don't have to do the same thing as you do for an INH-based regimen, which you tend to monitor a lot of people monthly. Some people maybe you're not if they have normal livers at baseline and no other risk factors for hepatotoxicity. But so many people are on so many drugs now that potentially cause hepatotoxicity. You're often boxed into monitoring for INH monthly. That's probably all I got. I mean, just in terms of pearls, I guess just feel free to drop an email or reach out if you have questions or run into problems with the patient. So.
Yeah, another question I've just realized I get is changing regimens in the middle, and can you count some of the doses from the other regimen? And I think the answer to that is yes. So I don't know if you want to talk about that a little bit, Kevin, maybe.
Yeah, I mean, your third question was kind of on that one, right? I mean, the question is whether whatever you're doing can kind of count towards the larger goal. And the nice thing about the rifampin-based therapies is you can always just kind of switch to them. What I run into clinically is someone takes INH rifapentine for a month, and then rifapentine's out of the pharmacy, or they don't want to keep doing it. So I would give them credit for that month, and I would complete them just with rifampin, or INH rifampin together. I mean, either one of those would be ideal. People who are on rifampin for 2 months and they can't tolerate any more of it, you're kind of SOL. You could give them credit for the 2 months, which I think you probably should, and then you'd have to switch them to INH, but I guess you probably treat them for 7 more months. So that seems reasonable to me. Of course, there's no data to say that works as well as 9 months INH or 4 months rifampin, but that would be the rationale. So I think when you run into individual questions like that, it's just best to reach out to Heidi and I. We can kind of give you some advice.
Yeah. Okay, great. All right. Thank you everybody for joining us. World TB Day is March 24th. So we just kind of honor World TB Day all month. But thanks everybody for joining. Data of 2024 data for TB disease will come out probably after March 24th, but around that time.
Yep. Have a cocktail on World TB Day for me. That sounds good.
All right. Thank you, everybody. Bye-bye.
See you guys. Cheers. Bye-bye.